So, let us continue with the severity. I'm sorry, I got something in between, so I'm really sorry for the interruption. So, we are talking about the severity of the patient who is suffering from type 1 Mobitz classification. So, if you talk about the severity of the patient, usually there is no much, like I would say, there is only a benign kind of symptoms found in. I'm sorry for the spelling mistake. Benign kind of symptoms found, and there is no specific treatment needed for the for those who are suffering from type 1 Mobitz classification. Usually it is usually treated by giving the patient with antiarrhythmic drugs such as lidocaine or either amiodarone, which I'll be discussing about both these drugs later. No specific treatment is needed. Now coming up to the second type of classification, what we call it as type 2 Mobitz classification. So how do we as I have said in type 1 Mobitz classification, usually the ratio is in the form of 4:1 or 3:1. Like there is only one dropping of QRST complex in a type 1 Mobitz classification, but if you take it in type 2 classification, the ratio may varies. Usually the ratio will be around 3:2 or 2:1 or around 4:2. Means it implies that if there are continuously formation of 3 PQRST complex, then there are chances of dropping of 2 QRST complex. I'll be continuing that the diagram above here below here. So if consider if there are continuous formation of 3 PQRST complex, then there are high chances that there would be dropping of 2 QRST complexes of two QRST complexes and formation of 2 P waves. So this is the difference between type 1 Mobitz classification and the type 2 Mobitz classification. So if we talk about the severity of the cases, severity of type 2 classification is usually there are high chances that the patient may either suffer from cardiac arrest, so or either the heart attack, what you call it as myocardial infarction. So severity is high, chances of cardiac arrest and MI, what you call it as myocardial infarction or heart attack, infarction, are high. So the treatment needed is we have to insert a kind of pacemaker, an artificial pacemaker, what you call it as, which is usually responsible of conducting impulses, as the AV node is will be not able to conduct the impulses. So usually a pacemaker is inserted towards our right ventricle into our chest. The region we usually call it as precordial region. The region in the chest where the heart is present is called as precordial region. So usually the pacemaker is inserted toward below the right ventricle and towards the like right part of our heart. So treatment is insertion of pacemaker subcutaneously or in front of the chest. Okay, hope you might have got about the second degree heart blockage. So the last one, the last type of blockage, what we call it as third degree blockage. We also call third degree blockage as complete blockage. So like, what is the phenomenon and what are all the aspects we see if a patient has got third degree blockage? So we'll be discussing about that now. So like, if you talk about the third degree blockage, there will be complete arrest of impulses which are conducting from atria and transferring of impulses from the atria to the ventricle. So let us write it down over here. There will be complete cessation of impulses forming from atria and transferring to the ventricle. Means like, there will be a kind of like what we say, there will be no like conduction of excitability or any kind of impulse conduction in the heart. Usually the pacemaker, what you call it as SN node, the SN node will SN node has completely lost its ability to conduct the impulse, and AV node has completely lost its ability to conduct the impulses from atria to ventricle and passing the impulses from AV node to the bundle of his and into the Purkinje fibers. So this is the first point which has to be remembered. And like, if we see in terms of ECG report, usually there will be complete cessation of formation of QRST complex. Do you like, if I ask you the question why there is no formation of QRST complex, if a person is suffering from third degree blockage, and if you take the ECG report of the patient who is suffering from third degree blockage, and you may see like there is no formation of QRST complex. So what would be the reason like there is no formation of QRST complex? So the reason behind it is, as there is no conduction of impulses from atria and transferring of impulses from atria to ventricle, so there are ventricle will be not able to depolarize itself. Means there will be complete failure of ventricular depolarization. So let me draw the QRST complex here, like the ECG diagram regarding about third degree blockage. So this is the thing. It will be like this, a kind of wavy type. There is only formation of P and R wave, but there is no complete formation of no QRST complex is formed. So the reason behind is failure of ventricular depolarization. Ventricular depolarization. So like this is that's all. Like we have covered about the types of blockages and like what are all the aspects and what are all the considerations to be taken if we are classifying about AV node blockage or junctional blockage. So how do we classify the three types of blockages in terms of ECG aspect, and how do we classify the second degree blockage in terms of the formation of QRST complex and the for cessation of P wave or either QRST complex. So the next thing we'll be dealing with is about the most prominent syndrome seen in third degree blockage, what we call it as Stokes Adam syndrome. Stokes Adam syndrome. So what do you mean by this? What usually this type of syndrome is found in patients who have got third degree blockage, what you call it as complete blockage. Like what is the mechanism and what are all the aspects and what are all the clinical symptoms we see here. So let us discuss about that. So if we take an example, as I said, in third degree blockage there will be complete cessation of conduction of impulses from atria to ventricle. So as there is complete cessation of conduction of impulses from the atria to the ventricle, there will be no sound of heartbeat, because as there is no conduction of the impulses, then there will be complete cessation of heartbeat. So during this time what happens is, even if there is a conduction of sinoatrial node, even if the pacemaker of our heart, what you call it as sinoatrial node, even if there are chances of conduction of the impulses from SA node to AV node, as we have discussed, it has got an adaptation that it delays the conduction of impulses from AV node to the bundle of fish for about 0.1 second of period. So what happens if this delay increases up to 5 to 30 seconds? So if the delay in the AV node increases from 0.1 second to highest point, what we say, if there is increase up to 5 to 30 seconds, what happens? So if there is an increase in a delay of 5 to 30 seconds, we call this phenomenon as overdrive suppression. Let me write it down over. If the delay in the AV node increases about 5 to 30 seconds, then this phenomenon, we usually name it as overdrive suppression. What do you mean by overdrive suppression now? What does it mean? So if we talk about overdrive suppression, usually what happens is the ventricular excitability is first suppressed whenever there is the conduction from SA node, because what happens usually is ventricular as I've mentioned in the previous lecture, ventricular contraction is totally dependent on atria, because the impulses are transferred from SN node to AV node, and from AV node it is transferred to the ventricles. So we can say that ventricular contraction is totally dependent on atrial contraction. So what happens now is, like, whenever I'm sorry, let me write it on the let me write down the first point. Ventricular contraction is totally dependent on atrial contraction. So, like, if you talk about, as I have said, like, ventricular contraction is totally dependent on atrial contraction. There are some cases, as I have said, there are some cases where ventricular start like it overcomes the dependence of atrial contraction. There are some cases that ventricles overcome the dependency of atrial contraction. Do you know why? Like, what is the reason behind, like, ventricles overcome the atrial contraction, dependency of atrial contraction? Because that ventricles will start getting some ectopic impulses. As I have said, the ectopic impulses are those impulses which are generated from the other part of the heart, from the Purkinje fibers which are present in the heart. Purkinje fibers, where the velocity of the impulses or the time period, or if we also call as time period, out of impulses is about 15 to 40 times per minute, and this impulses starts acting as pacemaker to the ventricles. So I think you got this point. So this phenomenon where the ventricles will overcome the dependency of atrial contraction is called as ventricular escape. This phenomenon is called as ventricular escape. Now coming up to the most important point, like, as you have said, like, there will be decrease in heartbeat whenever whenever the patient has got third degree blockage, and due to the decrease of heartbeat there will be, like, less blood supplied to the systemic circulation and even to the brain. So as we are known with the fact that brain doesn't persist without blood for around only 4 to 7 seconds. So as I have said, there will be severe case of bradycardia, and due to this, like the heartbeat get decreased, and there will be like less blood supplied to the all organs of our body, including the brain. So what happens if there is like uh, uh, less supply of blood to the brain? So the patient starts like he feels like fainting for some period of time. So the patient who is suffering from third degree blockage faints, and after some time there is a beautiful phenomenon here is like, and like even soon after the patient faints, then there is the phenomenon occurs what I previously explained is ventricular escape. So the ventricular starts contracting. Whenever ventricular like it starts contracting its own, immediately the blood supply will like increase by itself immediately due to the contraction of ventricles, and this will this will leads to the rapid recovery from the pain, and it helps in the sustaining the patient from the less blood supply to the brain. Usually we have got many syndromes. If like I'll be discussing about those in the upcoming videos. We have got another beautiful reaction, what you call it as Cushing's reaction. So even if, this Cushing's reaction occurs in the brain when there is a less supply of blood. I'll be discussing this Cushing reactions in short term regulation of blood pressure. So I'll be only dealing with the current topic, what is called as Stokes Adam syndrome. So like as I have said, when there is a starting of ventricular escape, automatically the blood supply stabilizes itself due to the contraction of the heart and generation of heartbeat. Blood supply gets stable, and the patient sustains from the faint. So usually this type of fainting will be seen in the patient for several periodic time. So this type of periodic fainting is regarded as Stokes Adam syndrome. So this type of periodic fainting is regarded as Stokes Adam syndrome. So like that's all I wanted to discuss with you all guys. So I hope you might have got the topic which I taught today. So I thank you all for your attention, and please if you like if you are really interested with this video, please have a look on this video completely, because I don't think so I have tried my best enough to get the content like this. So Please watch it carefully and enjoy the video. And I thank you all for your attention. And goodbye. Have a nice